Hi, everybody. My name is Jasmine, and today I'm going to go over the newborn transition lecture and the risk factors associated with being born, basically. And this is for JCC students. This will not necessarily work for every single nursing student. This is just helpful for me, for my own purposes, and I hope that it helps my classmates too. Whew. All right. So, jaundice. There are four different types of jaundice that an infant can go through. One of them is called breast milk jaundice. What is breast milk jaundice? Breast milk jaundice is occurs when the mom is feeding the baby and they're showing signs and symptoms of jaundice. Um, but the thing about this one is that the breast milk is the culprit behind the jaundice. So there's something going on in the mom's breast milk that is not or that is inhibiting the baby's liver to convert that to use that protein to convert the bilirubin to be excreted. So something's going on. And those babies, the moms who have messed up breast milk, or I hate to say messed up breast milk because that's what it is in layman's terms, um, they're probably going to go on formula. It's just, it's just not working. And this reminds me of maybe if the mom never had any prenatal care in her first pregnancy. They have completely different blood types. So maybe the mom's O negative blood type is affecting that baby's A positive blood type. So even if that baby were to breastfeed from that mom, it's those those immunoglobulins in there are still not working for that baby, even though that is her baby, but it's just not working. So that sort of helps me sort of understand that. The next type is breastfeeding jaundice. So breastfeeding jaundice is a type of jaundice that where the mom is breastfeeding and everything's going good, but for some reason the baby's not getting enough nutrients it needs it's not absorbing enough um, to convert the bilirubin to conjugated bilirubin to be excreted out. So what the doctors actually recommend is that they're going to tell her to keep breastfeeding. And the reason for that is maybe she's not getting to that high milk when the milk starts to get mature. Maybe she's not feeding the baby for the 10 to 15 minutes she's supposed to on each side. There's something going on. So they're actually going to recommend the mom keep feeding the baby um, just to help the baby. Or maybe the baby's body is so slow in the liver um, doing its job. Because the liver, you have these larger red blood cells, you have a low amount of blood cells, and the liver is still immature too. So it's having a hard time trying to do all these things that now it's been forced to do in that transition period. All right, so the next ones I'm going to talk about are right here, physiological and pathological. So physiological aspects is what I was talking about earlier, the lifespan. The lifespan of babies' red blood cells is 60 to 70 or 70 to 90 days around that time, but definitely less than 90 days. Whereas ours as a adult are 120 days, which is way better because we have stronger, we have smaller, and we have more mature red blood cells. The uptake. So physiologically, the liver may be slow to uptake, like I was talking about earlier. Slow, too slow, super duper slow. Another reason why, let me turn my page, make sure I'm getting all the key points for liver on this. All right. Another key point is that when we're talking about the in regards to, when I was talking about in a previous video, the blood coagulation with the vitamin K that's synthesized by the liver and then it's absorbed into the intestines. The intestines and the liver work together um, to help the baby's process. So maybe the intestines is having a problem um, well, it is having a problem doing its job. Bacteria. Another, well, she said specifically lack of intestinal bacteria. Another reason would be poor hydration. Because remember, you need to hydrolyze that bilirubin with that protein to get it out. If the baby is not hydrated enough, that can cause it too. Not to say we never put water in bottles, never, ever, 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 ever. But maybe if she was formula feeding, or hopefully she's breastfeeding, if she's formula feeding and she's not doing the correct measurements, water does nothing. I mean, it's helpful when you get older, but it does nothing for a newborn. It has no nutritional value, and they can literally waste away. So if you see anybody with a bottle on a newborn and it's sugar water, Lord Jesus, no, don't do it. Um, and another thing, physiologically speaking, and we just talked about breastfeeding. So breastfeeding is in regards to this physiological factor too. Now, why is this bad? Well, obviously, skin turning yellow is bad because bilirubin is a waste. But when it goes into that extravascular space, it can cause brain damage. And the main one, I have a star here for that. And the main type of brain damage it can cause is hernitus, which is also called acute bilirubin encephalopathy. It will cause severe brain damage. So you just want to be sure that not only the parents know this, but you know this as well, and the importance of getting that down. Now, total bilirubin does peak within 72 to 168 days. I know hours. Ooh, I know in my previous video I said 3 to 5 days, but in this lecture it says 72 to 168 hours, which is 3 to 7 days. So, yes. Now, pathologically speaking, pathological bilirubin appears within the first 24 hours. Now, initially, when a child is born, they will be slight jaundice, but it should go away. It shouldn't last that long. For a preterm child, if they're preterm, obviously they have a very severely underdeveloped liver. So it's going to last greater than 2 weeks max. That's how you know they have pathological jaundice. If it is a term child, if it lasts over a week, because remember I just mentioned that it peaks at, you know, 3 to 5 days or 3 to 168 hours, 3 to 7 days. If it is greater than 8 days, that's a problem. That's pathological. And the percentile of bilirubin is if it reaches 95%, and the percentile, you know, and then if the bilirubin total serum bilirubin level, as in when we draw the blood, is greater than 2 mg's per deciliter, that means they're at risk. But if it's over 5, they are at absolute risk, like completely. Okay. Um, Now, how does jaundice occur? In the placenta, you're supposed to, the placenta usually clears the unconjugated bilirubin, and the liver must then do its job. So I mentioned in another video, the liver cannot have the bilirubin bind to proteins. Um, you will have the free fatty acids, which can lead to decrease in blood pressure, decrease in temperature, which reminds you of cold stress, okay, which I mentioned in another video. Uh, but again, we worry because extravascular tissue, acute bilirubin encephalopathy. That's why we worry about this baby, because it can cross a blood-brain barrier. Um, now, who's at risk? So I'm not going to mention the obvious ones I think are obvious. If you have family history or East Asian descent, okay, you have a higher risk of getting jaundice. Now the other ones that are not so obvious are encephalomatomas. All right, because what is a cephalohematoma? A cephalohematoma is basically a brain bleed in the brain due to use of forceps or vacuums or a very prolonged labor. So what happens? Why is it so important? You have all these red blood cells in this one area, which is increasing your blood cells. But if you don't have the capabilities to get rid of those blood cells, that's a risk factor for jaundice. Um, because you're increasing your breakdown. And what it actually is that it causes this bruise. And also risk factors too with cold stress. I'm gonna put cold stress up here. Cold stress in regards to hypothermia, hypoglycemia. Okay, did I miss one? Nope. All right, and medications. Medications. So, what type of medications can actually cause jaundice? So, you have oxytocin and I can never say this one. Buprevacaine. Buprevacaine can cause jaundice. I don't know what buprevacaine does. Don't ask me. It was in the in-class Tessie book. Within this book, I do believe. Um, but yes, those two can cause jaundice. And also uh, asphyxiation in regards to core compression when they're born, which are risk for which type of gestational age babies, the longer gestational age babies, and also if they're premature, obviously, and if they have an O negative blood type, which I sort of discussed when I was talking about the breast milk. So what are our nursing actions? Okay, I forgot to write that down. Oh my God, get your life. Okay, so our nursing actions. We're gonna check vitals. It's supposed to be a check sign. Check check vital signs. Every 2 to 3 hours. Jaundice. The next thing we're gonna do is, and we're gonna assess them every shift for obvious reasons, because this can probably go 0 to 100 real quick. And then we're gonna check for dehydration, skin turgor, decrease, uh, indented, pointed nails, weak cry, like just dehydration has a slew of symptoms in itself. You can tell when the baby's dehydrated. They just look so sad. Anyway, so dehydration, vital signs every shift. We have to do our when dehydration goes. So how would you know if a baby's dehydrated from jaundice? You literally have to do their weights at the same time each day, and eye and nose, ins and outs. Um, and the first day, they're not going to have as many diapers. So the first day, they're going to have one diaper, second day, two, third day, three, fourth day, four, fifth day. At the fifth day, they should have between 6 and 8 wet diapers a day. And that can tell you, like, something's going on. Um, so you want to do that, and then you want to do their TCIs. So TCI in orange. All right, so the TCI is two color icometer, and that also known as the Billy strip. You see that? Probably not. Dang it. But it really says TCI Billy strip, and what that does is that's actually comparing the color of their skin to a strip. And usually jaundice occurs from the nose out. So when you press on the nose of the babies, and just for P's and Q's, if the babies are of African American descent, you're going to have to probably check their eyes and their mucous membranes. Now, when my son was born, he was very, 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 very light. So you can really tell, very, very light. And I was a little worried about that. But nursing knowledge has told me that that's normal because he's not been in the light. So why would he be brown when he comes out? But but that's a little funny. But for children who are born with color, usually African American babies are born a little brownish gray. Some of them come out really beautifully brown. You have to check their eyes and their mucous membranes and their nails. That's the only thing it's really going to tell you. Um, and then you're going to check uh, as needed and before discharge. And you're going to have to expect the doctor to order a bilirubin serum test. Um, Now, other diagnostics or labs, because this color is like horrible. And no one can see about all these colorful markers for no reason. Um, so I'm going to erase this because these are nursing actions. We just talked about this. But we're going to talk about the test. So, whew, so the indirect test, they refer indirect as in the unconjugated bilirubin, and the direct Combs test is in regards to the conjugated bilirubin. So the Combs test or Combs or whatever you want to call it has two O's in it. Let me put it right here. The two O's. Pretty sure it has two O's. Combs. Yep. Ha! Okay. So Combs test. This actually detects if the mom has some kind of hemolytic disease. And it's antiglobulin test. And IgMs are used. Uh, are IgMs are the babies. IgGs are from breast milk. IgGs are from in the womb. Okay, IgGs they actually detect those immunoglobulins that the mom passes on to the baby. Um, and it can actually tell if those maternal can't see this either. Oh, Jesus. There, it's better. No, it's brown. All right. It will actually test, let me write this down, antiglobulins to detect a hemolytic disease. Okay. And it will actually also, when it's detecting this, it will detect whether or not the mom's antibodies are on the baby's blood cells, preventing them from properly getting rid of bilirubin. Other tests they're gonna do, and you can do a hemoglobin level test. You can do a serum bilirubin, obviously. You could do the reticulocyte percentage. If you don't know what reticulocytes are, they are the immature red blood cells that really don't know how to do anything. They're sort of baby blood cells, and the white blood cells. So, in regards to this, how do we know? How are we going to treat them? Okay, all there's three things that based on our treatment is the bilirubin level, the age in hours, and the weight. Okay, those three things are the things we need to try to treat this baby who has jaundice. Now, the first treatment I want to talk about is phototherapy. I'm gonna erase this because really don't need this anymore. All right, so phototherapy. What is phototherapy? Phototherapy is therapy that is used to correct the bilirubin in the red blood cells, and it is a light that promotes hydrolysis of red blood cells and for the baby to actually pee it out. Now, I'm going to talk about these because I don't feel I'm gonna like. I think these are not that hard of a concept. Okay, so phototherapy with babies. Okay, so the phototherapy with the babies. basically you want them, it's used to help get that bilirubin out. Now, it's a light. They either are in a insulet or a crib. They usually only have a diaper on. There can be certain certain hospitals that have them with nothing on their bottoms. But most our teachers said that they recommend a diaper to prevent any type of burns or injury to the genitalia area, because that area, especially when girls are born, is sort of red and swollen. Um, Sometimes, not all the time, but in the boys, you just want to be careful. Um, and they're gonna have eyes. They're gonna have like black glasses on or sunglasses or eye protection to help it not penetrate their eyes or hurt them. Now, when they're breastfeeding, you could take them out, have them on breastfeed, and put them back. Um, because that does help. Breastfeeding does help prevent jaundice, unless you have breast milk jaundice problems. Um, Now, what else I want to talk about with that one? Nursing actions. Oh, so with this too, we have to make sure we monitor their eyes and nose because they are getting rid of water. So you want to monitor for dehydration. Um, let me see. I already talked about that. And you want to cluster the care, cluster the care. With phototherapy, within 4 to 6 hours, that phototherapy level should be, their bilirubin level should be down at least 1 to 2 mgs per decimal liter. Um, and you want to, as a nurse, change their positions altogether, which is a safety thing. You don't want to, especially if they're preemie or something like that, or they're weak, or they're SGA babies, you want to turn them all together to prevent ICP, because that's just bad. But in general, you just turn babies all together. Don't turn their head and then turn their bodies. No, just lift them up and turn them so it gets through their body equally. Now, okay, what else to talk about? All right, so let's say they did the phototherapy and it didn't work. So what are they going to do now? They're going to do, and the goals for phototherapy and the exchange transfusion are exactly the same. But for some reason, the phototherapy isn't working. So the exchange transfusion is when they take 85% of the newborn's blood and replace it with the donor's blood, to help do a few things. It's going to remove those maternal antibodies. It's going to remove toxins. It's going to correct that anemia, especially if the mom is Rh negative. Okay. And it's going to help correct that bilirubin. Those are the 4 goals for both of those. So I'm going to say it again. Maternal toxins, maternal antibodies, toxins, bilirubin, and anemia. Those are the goals for both phototherapy and exchange transfusion. And I think I mentioned everything. Yep. And that's it for jaundice. So I hope you guys like my video. I hope it was helpful. Yes. All right. See you guys next video. Bye.